Welcome back to PCICU. I'm Zach Hodges, a pediatric ICU fellow from UT Southwestern in Dallas.
And I'm Alice Shanklin, a critical care fellow at Children's National in Washington, D.C.
Alice, will you remind us what we do here at PCICU?
Absolutely. PCICU is a pediatric critical care podcast. We're looking for the best bedside teaching spiels from around the country and the world, and we are putting them on the internet for you.
And today we have another core topic in pediatric ICU medicine. What are we talking about?
Yes, today we're talking about the fundamentals of CPR. In this episode, we cover everything from how to come in and physically structure your room for a successful resuscitation to how to keep the coronary perfusion pressure adequate and get the airway in without compromising your chance of ROSC. Zach, who are we speaking with today?
So today we are lucky enough to have two guests. Our first guest is Dr. Tarif Choudhury. He's a pediatric cardiac intensivist at Columbia University. He completed his pediatric residency at Cohen Children's, followed by his cardiology fellowship at Lurie Children's, and then finally his PICU fellowship at Morgan Stanley Children's Hospital. His areas of interest include simulation and improving team dynamics, and it's very clear as you hear his conversation and how he optimizes everyone to function at the top of their ability during a cardiac arrest.
Yes, I would love to see Tarif run a code. We also have Gav Apfel. You guys remember Gav, he's our boots on the ground in Columbia. He is currently a cardiac critical care hospitalist. He just finished his residency there, and next year he will be joining their PICU fellowship program.
Yes, let's get right to the episode. Welcome back to the podcast. We are so excited that we have two guests with us today. Welcome back to the podcast first, Dr. Gav Apfel.
Thank you very much.
And welcome to the podcast, Dr. Tarif Choudhury.
Thank you, Zach and Alice. Big fans of the show. Thanks for having me.
Oh, thank you.
Yeah. Tarif, to get things started, will you tell our listeners a little bit about yourself and feel free to include something you enjoy outside of medicine?
I'm a pediatric cardiac intensivist at Columbia. I'm a native New Yorker. Grew up in the Bronx for the most part, although I was born in Jersey for most of my life. I spent in the Bronx until my early 20s. And I did my cardiology fellowship between the Cleveland Clinic, where I first started after finishing 1 year, and completing it at the Lurie Children's in Chicago at Northwestern. Then I was followed up with return back to New York, where I did my PICU fellowship at Columbia in Manhattan, and graduated from there as a cardiac intensivist, and has assumed that role now for, going to be about 6 years, and still learning a lot every day. On faculty in the cardiac ICU at Columbia, and I sit and have appointments in both cardiology and critical care.
Oh, we are always so humbled when we hear about someone fully dual boarding. So, how did you become interested in cardiac intensive care specifically, and what areas of the CICU are you most interested in right now?
Alice, it's funny. It's one of those things that a lot of us find kind of innate passions or innate interests, right? Interest I found in medical school, in embryology. And I found there was a bridge from that to a job in the future as a pediatric cardiologist. And I said, oh, this could be kind of neat, right? And then after teaching my colleagues in medical school, and whenever it was time to get ready for the shelf exams or in-services or what have you, I forget now, I'm so old, I'd find myself really enjoying the experience of knowing it so well and explaining it to my friends that this must be something I'd probably find myself being interested in doing one day. And then you probably all had some version of a physiology textbook as well, and I had Guyton. And I remember the Guyton textbook finding myself also interested in the physiologies of the other organ systems, just wasn't sure that I was going to make a living out of it. And pediatric residency introduced me to that other profession, critical care as well. And just like many of us, we have people we look up to. I had near peers, I guess, for lack of a better word, who were fellows at the time. And at that time were the earlier cardiac intensivists to be in the making. And I found some of them when I was in my residency at Cohen's here in the city in Long Island. And watching those guys grow up and watching what they could do in their breadth of knowledge, I thought to myself, I want to do both of these things. I want to be really better prepared to care for the critically ill child with congenital heart disease. And then cardiology fellowship solidified it. I enjoyed the cerebral act of making sense out of the data, but I wanted to be able to act quickly and be able to really harness the power of all the organ systems and understanding that. And I saw my colleagues in PICU fellowship. So it was exposure to great friends that taught me and great colleagues that taught me I wanted to do both. And there was, in my mind, only one way to do it. And those both fellowships. And a very patient wife, at that time fiance and girlfriend, and a patient family in my infant that was watching me grow up as a young attending into now a junior attending.
Oh, absolutely.
I wanted to ask what advice you had for intensivists in training and their fellowship and, even attendings who are just starting out in, let's say, their first clinical job, who haven't had necessarily the significant clinical experiences yet. Any advice regarding prioritizing their mental health, their well-being, especially while working in the ICU where you're surrounded by such significant critical illness? And in particular, more related to our topic, when you are exposed to so many arrests and or cardiac arrests in children, both of those could be significantly emotionally draining and mentally draining. And I was wondering if, you had any particular outlook or advice for those of us who are just starting out.
It's a great question, Gav, that we commonly get, both the PICU and the cardiac ICU. This concept of an outlet, how do you decompress after having what could be an emotionally and physically taxing day and days? And for me, I have a luxury that many of us maybe otherwise might not have. I have a wife that's also a pediatric intensivist.
No way.
Yeah, shout out to my wife, Gina, who's an intensivist here in New York in the Bronx at Montefiore. And we really love what we do to a point where we can discuss with each other how our days went in a more granular level. But in a more generalizable way, to answer your question, Gav, ultimately all I'm describing is a method or a person that you can decompress with and to. And my wife is a wonderful sounding board for me. And there are some other people in my life that I trust with that kind of information. Not HIPAA-breaking information, but the general way of how the day went. I think that's invaluable to have that kind of method of decompression. And then whatever makes you happy and really brings you to life. In addition to that method of decompression, what brings me to life is my son. I have a now almost 6-year-old son. I live life vicariously through him. So those methods of decompression are going to be invaluable for the young intensivist coming out of fellowship in terms of what home life and outside the ICU life. In the ICU, I think the most important thing to do is just embrace the humility of our field. There's a paper coming out every month about the way we need to change our practice in every aspect of our field. And that's if you're smart enough to understand the science already. And now you're ready to consume the data. Early on, the first 5 to 10 years, here I am still consuming the science. And if you're fortunate enough to share an office with a guy or gal that's been doing it for 30 years, talk to those people and soak it all up and return the favor. In 30 years, you'll be that person returning it back to that junior attending. But be humble and take advantage of those resources. Be open to saying, I don't know.
I really appreciate that emphasis on having faculty mentorship, even as an attending, focused on your clinical practice beyond just like research. So that's lovely.
And I really appreciate the comments about having that balance between the hard work that you do each day in the hospital, but also family at home. It certainly is a balance that we all try to find for our own unique circumstances moving through training and into that first job. What we say for all of our guests and all of our episodes, I don't anticipate this is the case, but do you have any conflicts of interest as we move into today's topic?
No, my NIH grant has not come in.
All right. Gav, if you would like, will you give us our case and our first question?
In our case, we have a 6-month-old boy who was admitted to the PICU, and he was intubated for respiratory failure in the setting of RSV bronchiolitis. He subsequently becomes severely agitated and self-extubates, and then deteriorates and suffers from a cardiorespiratory arrest. The bedside staff begins CPR, and a code is called. Now, we've seen in our unit, I think pediatric arrests are probably some of the most stressful clinical experiences for intensivists and pediatricians in general, as well as the families of the patients. What are your first thoughts when you're arriving on scene? How do you strategize in terms of approaching that code?
Locally, with our care model, and this is not going to be easily generalizable across all the care models, but I can at least speak for a common academic care model, which is I know who my team is as I walk up to the unit. And oftentimes I might even have access to a census as a refresher from the sign out that I got, or if it's my unit, I know my census pretty well. Why that becomes important, I think, is because as I walk to the bedside of the patient that I'm getting my code notification about, I have a second to take a deep breath and start to actually mentally rehearse what my team's probably looking like as I walk in. And I also probably have a pretest probability of what I think the mechanism of the child's arrest was based on the one-liner and the pretest probability of what the likelihood of getting the return of spontaneous circulation. All those things, believe it or not, going through my mind as I make my walk over. And I find that invaluable to actually have an idea of what my team's going to look like as I walk in and what the patient's probably going through right now and what I expect the patient to go through in the next 10 to 15 minutes. That way, if there's a deviation from any of that, what the team looks like, what the patient will actually end up turning out to be like, I can pivot. So those are the things that come to my mind as I walk to assist the fellow, because at the end of the day, the attending is just there to be the whisperer to the fellow's ear, right?
Yes. So you're walking up to this kid, you're thinking, I know this is a broncholytic. It's probably a hypoxic bradycardic arrest. We need to get that airway in as soon as possible, that type of thing.
Exactly, Alice. Because if the scenario is something other than that, in my unit, I have a mixed-like unit where I have 40 beds that I care for. And if Gav's running around caring for the 40 kids as a first set of eyes and ears, and I have a bird's eye view of those 40 just like he does, I know some of the other kids in the rest of the unit are potentially cardiac. And if I'm getting that same call, but it's a new BT shunt from that night, my mental rehearsal in my mind as I walk to that kid's bedside is a little bit different. And the natural history could look different. And the people I called to the bedside could look different. So from a crisis resource management perspective, a buzzword that I think many simulationists like to use, and I'm a simulation enthusiast, in terms of organizing the room, I organize my room and I think to myself, the resources that I'm going to allocate are going to be a little bit different in that room, the BT shunt arrest, from the respiratory arrest kit. The respiratory arrest kit, I'm going to think to myself, I've got the people in the room that I need, and if I can get this airway on a relatively quickly fashion, after I achieve an optimal setup of the room with good high-quality CPR for some period of time, if I can get the advanced airway in, maybe we'll have reversal of this disease in a fairly quick fashion. And if I don't, the resource that I might reach out for may be the content expert for the airway if I'm not able to achieve that airway. So my resource allocation becomes a little bit different if I'm called to the BT shunt patient, in whom that'll be a cardiologist at least, followed by oftentimes a CT surgeon to maybe milk the shunt or open the chest and maybe even go into ECMO. So I'm walking in with mental rehearsal already going on, and the one-liner or the two-liner making some sense on how I want to set up the room.
Excellent.
I think everything you said was so incredibly practical. Having that mindset when you show up in the room, what you're possibly dealing with, and what are those first few steps that you know you need to accomplish. When you do get to the room, and when I get to the room of a kid who's in cardiac arrest, I really find it to be like information overload. You see CPR in progress. You have those ideas about what needs to happen. Immediately, when you walk in the room, people know you're the intensivist. All eyes go to you. I'd like to know, how do you manage and how do you minimize the burden that comes with all of the information coming to you? How do you enable other people to function at their highest level?
Zach, it is so true. The stuff coming at you is at rapid fire, exorbitant amounts, and you walked in with just a couple of lines of thoughts, and you want to somehow distill it back to your original lines and thoughts, And for me, and this is my own style, which goes back to, again, a crisis resource management principle, which is summarize and re-summarize. Take this opportunity to leverage that principle in trying to distill the information. I heard from you guys that this was that 6-month-old, that broncholytic, right? This kid lost his airway, is that right? Next thing you know, the whole room is sharing a mental model of what you think is going on and the follow-up suggestion that's going to come up. This seems like it was probably a hypoxemic arrest. So let's try to get this airway in an orderly fashion. Let's perform CPR. Let's make sure that the roles are appropriately allocated. Did you mention to me that you're on compressions? And if so, what does the rest of the line of compressions look like? Is it 3 people? And who are those 3 people? Who's on the airway? Is it actually going to be myself or Gav? Or are we so committed to our respective roles that we're going to have to maybe incorporate a content expert just for the airway, assuming that the bag mask ventilation is going on okay by the nurse or frontline provider who's applying the bag mask ventilation? Who's the brains of this operation, otherwise known as the recorder? And are you to the left of me? And is CPR otherwise being administered the right way? And that surrogates of CPR, which I think we'll talk about in a little bit, are they actually going on the way I want them to be? After I've placed everybody in the right space and then get the room into the right headspace, where I read back to them the information they're saying to me in a more thoughtful, cohesive, and palatable manner, next thing I know, I've put people into a spot where we can probably have a higher chance of success before we get into the deeper details of the information that is valuable that everyone's trying to read back to me. I want to get this 1-liner, 2-liner to become a 4-liner, and eventually I'll get the rest of the paragraph.
I'm really interested to know more about the geography. You specified you want that recorder to your left. What other important geography do you have where you want people, particularly in the room?
Yeah, I'm a big proponent of setting yourself up for success, literally. And so you guys know as PICU fellows and soon to be PICU fellow Gav, you guys notice that we take a long, long time to set ourselves up for success, whether it's an intubation or a line. This is no different. And the setup in this case, especially, there's a nuance to showing up to the code that's already going on versus the code that you anticipate. The anticipated code, it's almost easier in the sense that you have control of how you're going to have this orchestra prepare for its music and its performance. In this case, the case that you guys described to me, I'm showing up to a performance story started. And I'm just trying to reorganize the orchestra a little bit. And oftentimes, at high-quality centers like myself and many of the ones that you guys will work at, the orchestra puts themselves into positions that you don't have to come in and finesse a lot. But in case you need to, you just say, who's the recorder? And they happen to be on your left or your right. That's okay. Left was just an example I was using you guys can tell probably right now, I'm mentally rehearsing a scenario that I wasn't even part of. It's a fictional scenario, right? But I'm at the foot of the bed, Zach, just like you're asking, in my room as I walk through the door. The recorder's flanking me to my left or to my right because he's whispering or she's whispering in my ear as I whisper into Gav's ear about what we want to do based on the information that the recorder is gathering. Then flanking the two sides of the child's chest, the left and the right hemithorax, are compressors. And then immediately adjacent to them is probably a nurse who knows the patient the best, hopefully the actual patient's nurse, primary nurse, who has immediate access to the vascular access. In that moment, in addition to all the information that I mentioned to you about putting people in the right positions, I will also ask, what's the child's vascular access? Can you remind me? Is it reliable? Do you have access to that right now? And they'll read back to me something along the lines of, yeah, actually, as a matter of fact, we gave sedation just an hour ago, and I know it kicked in because I gave it and the child responded. That nurse told me that the access is reliable. And then the head of the bed, as I move myself from south to north, for lack of a better word, from foot to the head of the bed, are the respiratory therapist or two, ideally bagging the patient. And if they're not readily available because your care model doesn't allow for a respiratory therapist readily available to you at your center, recruit them while in the meantime, obviously getting some other colleagues to help out, whether it's a nurse or a nurse practitioner, bagging the patient. And then there's the inside the room, there's the border, and then the outside the room. On the border is a charge nurse, somebody that you can trust to really control the crowd and maybe disseminate information thoughtfully and meaningfully between the room and outside the room, because the arrest team is only starting inside the room, but the arrest team completes outside the room. And those who are corralling, you're a Southern guy, Zach, so they're corralling the arrest cart and they're drawing up their epi, and that charge nurse is able to distill the information out to that arrest cart. And then the Zoll will hopefully make itself into the room at the foot of the bed, and the pads get placed onto that. That's the way I mentally formulate what I want the room to look like and what I want the room to eventually look like if a guest were to arrive and wonder what's going on.
Yeah, that's fascinating. I can even just see a mental map of that in my head, how it all lays out perfectly. And it's easy to see how you could equip people to function at their highest level in that space. You said something really interesting. You said, Gav's your future first year PICU fellow. You said you're whispering to him what needs to happen next. And that gives me the impression the room needs to be quiet. So will you just help me understand how you handle noise and chaos in a situation like that?
The cardiologist in me can't help but describe it as a crescendo-decrescendo type of sound. But the reality is it starts off, things kind of erupt, and then it slows down again, right? And there will inevitably be that crescendo-decrescendo. It's just a matter of how long the murmur has to last for lack of a better word, before you bring it back down to earth a little bit and make it a little bit of a softer pitch. And what I'm trying to tell Gav is what he's going to model for the rest of the team ultimately, the anticipation, another crisis resource management principle. Anticipating so your team can anticipate the next moves. Hey, Gav, it sounds like the recorder just told me 2 minutes is going to be up. Let's plan on a 3-4 minutes for the epinephrine, which obviously is room for debate about how often it's going to be, which I'm sure you guys will maybe have questions about. But that way, he's being that sounding board or that microphone for me, and as he becomes solely independent of all of us as attendings in general, and he lets the room know what he's going to expect from the team, that the epinephrine will be coming your way every 4 minutes, and that's going to be in concert with the fact the compressor is going to be switching every 2. So there's that time mark. And if that's not happening, I have that charge nurse that I'm entrusting with hope to achieve crowd control. And if it's not, because there are different levels of experience across our teams, and even in the most experienced charge nurse's hands or experienced team members' hands, you still need one more opportunity, one more chance to say out loud, can we just get the noise down? I'd like to hear what everyone's thoughts are. Not as much to put the focus on us, but to put the focus back on the team. Because if the thoughts aren't shared across the team, we won't be able to be successful. The next thing you know, everyone's got skin in the game. Not just about quieting it so I can think for myself, but so the team can think for itself.
And maintain that mental model that you work so hard to achieve.
Yes.
I just want to say, as the start date for my fellowship becomes increasingly closer, I will appreciate any and all whispering necessary that you can provide.
Yes.
In July and August, there's not a ton of whispering. It's just a lot more modeling at first. And September, October, slowly the whispers start to kick in.
That's so great.
Tarif, I was wondering if you could just walk us through some of it's a buzzword we typically hear about high quality CPR. If you could just walk us through what that include.
There's physiologic expectations and physiologic principles we need to adhere to achieve high quality CPR. So from a back to basics perspective, I think if we actually aim for our physiologic goals we can revert back to what our performance targets are going to be and then come back to what the physiologic targets are going to be as a result of those individual performances. And from a physiology perspective, it's about trying to achieve cerebral perfusing pressure that's adequate to perfuse the brain. And it's about trying to achieve coronary perfusing pressure to hopefully achieve return of spontaneous circulation. So just from a back to basics perspective, it's tough to ignore the need to incorporate what a coronary perfusing pressure is in our explanation, right, as our thoughts. Not to say that we would ever go through this during an actual code, but at least if you share the mental model of what you're trying to achieve, it'll make more sense to you as you're trying to make suggestions during the code. So from a back to basics perspective, we recall that coronary perfusing pressure is the diastolic blood pressure minus your right atrial pressure, assuming that the LVEDP is normal, which in the cardiac ICU, you can make that assumption sometimes. But let's take this child as an example who's otherwise a respiratory arrest. We are trying to achieve high quality CPR where hopefully you're applying a cardiac output that will ultimately result in resumption of return of spontaneous circulation, which is going to be dependent on optimizing the delta between diastolic blood pressure and right atrial pressure as a coronary perfusing pressure. In addition, a cerebral perfusing pressure that will be adequate enough for you to hopefully not have a significant neurologic sequelae. And from what you guys probably remember for PICU fellowship is the CPP, of course, is equal to your mean arterial blood pressure minus your intracranial pressure, which assuming this kid doesn't have that kind of pathology, it's just maintaining a certain map that's going to be adequate before you border the autoregulation zones. So for me, high quality CPR is cardiac output equals stroke volume times that heart rate to ultimately achieve a good coronary perfusing pressure. And that is a rate of 100 to 120. That's, again, suggested by the AHA, and depth that is 2.5 inches or 5 centimeters. Although there are other ways to determine that, because I think personally, I still struggle with actually visualizing the 2.5 inches or 5 centimeters mark. I don't know about you guys, in which case I rely on surrogates for that. But ultimately, if I come back to what am I striving for, it's mechanically for that, the cardiac output part of the equation, stroke volume times heart rate, while knowing that at best I'm administering, I don't know, maybe 30% of the cardiac output with closed chest compressions and epinephrine to increase the coronary perfusing pressure and the cerebral perfusing pressure as well.
Excellent. If Gav is running the code and you're monitoring the room, maybe you have a CPR coach, maybe you don't, and you're watching someone and maybe the speed is different than what the patient needs, maybe the depth is different. Do you have any ways that you like to correct specifically?
You know, Alice, I actually start off sometimes before correcting, and again, being a simulation enthusiast, I'm a big proponent of not just talking about what could be done differently, but what's going well, because the assumption that what's going well will be reproduced is a false assumption, I think. When a team performs well or someone is performing well, to assume that's going well all the time, I think is something that I take great pride in suggesting we should ask for more of. Are you doing this well? Let's call it out. So start off with, if compressions are going well, call that out. Nice job, compression. I see your pulse ox pleth with a peak systolic upstroke looking wonderful, or a diastolic on the arterial line looking like it's greater than 30. I see your end tidal greater than 20. Next thing you know, you don't have to call out the goals independently. Your team is following the mental model of what you're shooting for. So then the next thing you know, Alice, this is my back doorway into your question. When it's not going well, it's almost like self-reflection's allowing for that even before I bring it up. And I say to the team, guys, this time the diastolic is 10. I'm noticing that the end tidal is 10, excuse me. I'm noticing the diastolic is actually 15. And next thing you know, they can reference back to when the diastolic was 30 and how I called that out as something that was a positive feature, to ask for self-reflection by the individual who's noticing maybe they're just tired out. The 2-minute mark is an arbitrary mark, right? About how much time the compressor should be on the chest before they switch. Maybe they will take it upon themselves, or maybe even the suggestion will come up and say, let's make a switch. Let's see if something can change. While maintaining a genuine inquiry about, this may have nothing to do with the performer and more about the patient. I might not end up with an end tidal greater than 15 or 20. Yes, the heart rate can be slowed down. Hey guys, maybe let's go down on the heart rate a little bit and call it out. I notice your heart rate's 130. Be more objective if you can and say, let's follow that metronome and come down to 120 or 100, whatever marker of heart rate you want to use, whatever pace car of heart rate you want to use. Locally, we use a metronome. So again, it goes back to Alice, if I'm lucky enough to start off with good performance to start, use that as a reference. And next thing you know, the next suboptimal performance, you can reference back to the prior good performance. If I'm not so fortunate, and sometimes, again, the crescendo, decrescendo that is the room sometimes drives poor performance or suboptimal performance in the beginning, bring it back to, hey guys, the goals here, just as a refresher, are the following for the diastolic and the end tidal and the heart rate. And I'm noticing we're not achieving those physiological goals, and I'm wondering if we can come down on the heart rate. Maybe not all those words, but you can bring it back to the room and suggest to them, based on this metronome, I think we're going a little bit too fast. Based on that arterial line, I'm noticing a diastolic that's not suggestive of something with full recoil. Based on that peak systolic upstroke, maybe we're not pushing quite as deep as we think we are.
So listening to what you're having to say, it seems the most important thing is continually sharing that mental model of where we're at with our patient and where we need to go next. Is that fair enough?
That is, Zach. And having genuine inquiry, right? Before we make the assumption that it's the performance of the individual, is there something about the patient and the lesion? Maybe not the heart rate. Again, the heart rate is tough to ignore if you're just going to town at $140. But something about depth. Is it actually some data error in what you're seeing on the way that the ZOL is telling you the depth is going? I think some of my colleagues who are resuscitation specialists locally have shared with me that there are some limitations in how well the ZOL gives you feedback with pediatric and definitely the neonatal. I don't even know if the neonatal ZOL gives you that universally. At least locally, I don't think we have those pads. I don't know if you guys do. They give you actually depth on the neonate when the neonatal pads are placed. Pediatric ones, I noticed that there is some disconnect sometimes between what I'm noticing in real time and when we get the ZOL cards back and suggesting that the depth wasn't quite as great, in which case maybe there's some data error. And of course, the end tidal, again, if my goal is that greater than 15 to 20 goal, maybe it has something more with the disease. Maybe I have a pulmonary blood flow issue that doesn't allow for an end tidal. Maybe it has less to do with the performer. I'll tell you guys, as a Pacific pearl of my own that I've incorporated in the last couple of years, sometimes I will throw myself onto the compressor line just to get a feel of what's going on, especially in the cardiac ICU because the heart is all over the place. We have mesocardic hearts, dextrocardic hearts, and I'll actually put my hands on the chest just to see if I can get things to look any better with my own compression, just to clear my own conscience.
Interesting.
Will you tell me what you'll do with your hands to kind of maybe feel it out? Maybe there's a location of compression that you're aiming for. What's going on there?
So, Zach, as intensivists, it's tough to ignore the need to try to adhere to some kind of guideline. At least the AHA recommends that we use either the wraparound technique with the thumbs, the lower third of the sternum, or the two-finger technique on the babies. And of course, in the older kids, we have to get in on top of the child with hand over hand, avoiding a lean on all the populations, right? So if I'm noticing that the compressor is doing that thing from far away or maybe even close up, one thing I won't be able to tell for sure is what exactly is the force they're applying. And there is no way to reproduce it or conjure up a way to think to myself, how is that actually feeling? And the recoil to one person may look different from the recoil to another. What is a lean to one person may look like it's not a lean to another. And so what I'll do is, again, I'm still adhering to one of these three, which none of them have obvious supporting evidence to be superior to the other. Assuming that I can get the chest to have full recoil and a full depth, I'll put my hands on the patient's chest, hand over hand if it's a teenager or adolescent or pre-adolescent, and hand around the chest or two-finger depth, and just go a little bit around the chest just to find out if there happens to be a different location where I'm getting a better arterial line waveform, a better end tidal. In particular, as I said, in the cardiac ICU, because those kids' hearts definitely can shift either because of disease or just congenitally the way they were born. Sometimes it's also an opportunity to refresh your mind and actually ask the team, again, share information with each other. Christ's Research Management Principle. Hey guys, is this a heterotaxy? Dextrocardia heterotaxy? Oh, that's going to have implications when we place the pads as well, not to mention where we're going to compress.
You mentioned having a little bit of a lean, and I'm seeing this person have a lean during their compressions. I'm trying not to have that. Do you want to expand on what a lean is?
So I guess, Alice, I'm not going to pretend to say to you I have a scientific method of describing how much is too much of leaning in, as much as it is what was suggested by everyone who's taught all of us before us as well, is to not lean so far into the compressions as much as it stands a little bit more straight, because the lean will challenge your ability to actually allow for full recoil, right? From a weight perspective. If you're leaning in and down onto the patient, it'll be hard for you to get really true full recoil just from the laws of physics and gravity because you're leaning down and onto the patient. That's what I meant by it. But the problem I still find is, does this look like a lean to me or not? I'm not sure if I figured out a way to tell whether or not that's really looking like a lean or not. So again, just to clear my own conscience, I'll put myself onto that line of chest compressors to see if things can be any better.
So you've given us lots of great practical information. As a means of a summary, I thought I would just go over things quickly. So those key elements of high-quality CPR, optimal depth, rate, recoil. We've also talked a lot about how maybe there's some cardiac-specific considerations that maybe a dextrocardic patient or maybe some other Subtlety or idiosyncrasy might affect the location, but for the most part, we're following our guidelines. 2 hands around the chest for the babies, and then 2 hands overlying for the bigger kids. Use what resources you have, whether it's feedback for a Zoll. You mentioned maybe it's not always perfectly accurate, but it can be helpful in some situations, using a metronome, even a CPR coach. We're trying to restore coronary perfusion. You've told us the coronary perfusion pressure. It is the diastolic pressure minus the LV EDP. I feel like that's going to come up on a high stakes exam in the future. And then all the other practical things that you mentioned. We really appreciate that. As we transition now from the actual perfusion part of CPR, I'd like to bring in Gav now to give us a question about ventilation.
Sure. Yeah. Switching gears just for a little bit to ventilation and airway management. How does positive pressure ventilation affect our coronary perfusion during CPR? And how would you balance the benefits of, let's say, positive pressure ventilation and possibly the risk of impeding circulation?
Yeah, again, if we go back to what's our North Star, right? Our North Star is coronary perfusing pressure, and that way we can probably more comprehensively answer that question, Gav. And the North Star is diastolic blood pressure minus radial pressure, because that's going to give us our best chance to achieve maybe return of spontaneous circulation, or at least decrease the likelihood of significant myocardial injury if we have to even go on to ECMO or eCPR, right? So if I think about that and I have to go back to basics, we know that negative pressure breathing is the way we normally breathe. And if you think about the coronary perfusing pressure, the calculation again, diastolic pressure minus a negative number is going to result in a higher coronary perfusing pressure. So if you make that downstream number positive, you're going to end up with an ultimate summary of that equation to be a little bit of a lower number. So coronary perfusing pressure has now fallen. So ventilation is positive pressure ventilation, right? You're administering positive pressure ventilation, in which case now you've threatened coronary perfusing pressure. Add insult to injury, here you are with this mean airway pressure with each breath, and then you have these phasic changes of each breath. Start the breath, end the breath, start the breath, end the breath, whether it's invasive or non-invasive, and even worse potentially with invasive, because that positive pressure is directly being translated to the alveoli. And that's going to be that many times where coronary perfusing pressure is threatened with each breath. And as a result of that, we are very thoughtful about how ventilation, probably the right word is maybe even deliberate, what ventilation should look like. It should really look like ventilating only to FRC and nothing beyond, ventilating so the chest moves, and ventilating only the number of times that we think is going to be necessary for the cardiac output that is now 30% of the original cardiac output, right? At best, cardiac output is 30% of the original cardiac output with closed chest compressions compared to the healthy individual. So if you only need 30% cardiac output, you're going to need a lot less ventilation as well, which has its own surrogates based on the age of the patient you're caring for. So going back to our patient, the 6-month-old, you guys are probably aware of the recent guidelines from the AHA suggesting maybe liberating the ventilation goal a little bit closer to that 20 to 30 mark. And again, that's why it becomes so important to walk in with that pretest probability of what I think my patient's problem is, in which case I would hate to add a new problem, which is suboptimal ventilation. Hey guys, we're going to aim for 20 to 30, and as opposed to the lower rates for maybe some other diseases, some are age ranges. And let's see where we're at with that 20 to 30. Maybe even just say respiratory, can we aim for ventilation rate of around 25 and see where we're at?
Yeah, for sure. Great reminder of all the physiology going into these patients. I want to give you an opportunity to talk about your preferences or some thoughts for airway management at these codes. Reflecting on our case, we have the bronchiolytic who self-extubated. It sure seems obvious that placing an airway into that patient is going to be part of achieving ROS that's sustainable. But perhaps a case where you're not quite sure what the cause of the arrest was, if you don't have an airway, is intubating most often done in your hands when you're running a code? Or perhaps are there some situations where you would not place a definitive airway in a patient during an arrest?
Yeah, Zach, there's a couple questions in that. And I can envision, again, as we mentally rehearse a potential case that we've all been to, which is the kid off the unit, not in our senses. I don't know who the kid is until I show up, and in which case I try to then again set up the room for the first things that are most important. Is adequate CPR going on? Are the people in the right places for success? Do I have my 2 to 4 liner? And then slowly embark on the need or the importance of embarking on an advanced airway. And we talked a little bit about guideline-based approaches to today's pediatric resuscitation. And maybe it's an opportunity also to review what we think we are starting to learn, at least from the folks in Philly who are leading the charge with regards to resuscitation science, along with many other colleagues throughout the nation. But the folks in Philly really do a good job of looking into the important parts of CPR and what could threaten or augment the likelihood of having successful CPR. There's been recent scrutiny into spending too much time on trying to achieve an advanced airway. It's a provocative question because if the child's dominant lesion is a respiratory-mediated event, soon after you've gotten everyone into place, especially if you can bundle the task. I'm a big proponent of bundling tasks, which simulation can help you achieve what those bundles should look like, when they should happen. If you can bundle the task and you've gotten people with a couple of rounds of good high-quality CPR, you ventilated well, and you haven't been able to get return of spontaneous circulation, the next opportunity that you have, if it's really a respiratory-mediated arrest, and you have the content expert in that room, which in that case might just be me or Gav in that moment, just means that the cognitive load of what's going on right now in the room is best handled by us, and let's recruit one more member, which is your hospital happens to have a care model that allows for pediatric anesthesia that's in-house to come and just own the airway. After compressions have gone on for a good amount of time and the orchestra is playing on its own without the maestro and it's just going to go on seamlessly, then go ahead and achieve that advanced airway after everyone's in place so they can resume compressions pretty seamlessly. Because Bob Berg and the rest of the folks in Philly showed us that there is something to be said about trying to achieve an advanced airway in the middle of a code and potentially being associated with poor outcomes. I think it's more suggestive of the fact that it's probably a surrogate of pauses that occur during CPR. So if you can minimize those pauses and get an advanced airway, still try to achieve that as well.
A common time when people might take their eye off the ball in terms of pausing compressions.
Yeah. It's the concept of distractors, right, Alice? As we try to get our team to perform as high quality as possible, optimizing and prioritizing goals, and then seeing if everyone in the orchestra is in their respective positions to play music without any problems, and then just incorporate another member into the orchestra seamlessly. In this case, an anesthesiologist or one of us taking off our hat as the team leader and putting on the hat as the airway person in that moment. And then, Zach, to your point, if it's a different disease process, if I'm called to an arrest that happens to be a dysrhythmia-mediated arrest, we know that in the 3 phases of CPR, electrical, mechanical, and metabolic, especially of the electrical phase, if you can get on this kid's chest and put pads on and actually reverse the dysrhythmia early, for sure don't delay by trying to get an advanced airway where you should be just trying to reverse the dysrhythmia. Next thing you know, you might have a kid with ROSC in sinus rhythm who you're just bagging and having a relatively decent ventilation in whom that you're seamlessly and electively asking for an advanced airway. So the disease process matters, which is why after you're done with that 1, 2, and 4 liner, the room is calmed down, the orchestra and the members of the orchestra in their respective positions, then go to that person who knows the patient the best and say, so what's going on here? What is the kid's actual deal? Because at this point, Gav is running the orchestra and they're playing their music. Now I can really find out, how do we get out of this jam? We got into the jam. We're performing well in the jam. Now let's get out of the jam.
And thank you for listening to this episode of PedsCrit. Please remember that all content during this episode is intended for informational and educational purposes only. It should not be used as replacement for medical advice. The views expressed during this episode by hosts and our guests are their own and do not reflect the official position of their institutions. If you have any comments, suggestions, or feedback, you can email us at pedscriptpodcast@gmail.com or find us on Twitter @CritPeds and @PedsCrit on Instagram for real-time show updates. If you enjoyed the show, please subscribe, rate, and review on your favorite podcasting application and share with your colleagues. Also, if you'd like to support the making of the podcast, please see the description for Venmo information and how to become a Patreon. Any donation will be appreciated. Thank you again for listening, and goodbye.
Alice, poor Gav, we always introduce him as a soon-to-be fellow, don't we?
We do, but we're going to release this after July.
That's right. So I'd say congratulations, Gav.
Congratulations, Gav. Do you think that we're highlighting?
Great job. You made the fellowship. This is so great.
Should we just introduce him as a second-year fellow in case it gets pushed?
I think it's pretty likely he's going to be a second-year fellow when this comes out.
Depending on who edits.
Yep. No. I mean, regardless. Congratulations, Gav. Just wanted to say we really appreciate you being
sticking
a guest
with us.
Yes. And even though it's going to take us months for us to come out, hang in there. First year's hard, but you got this.
First year's, yeah.
Bye.
Bye.